Okay, today we're going to talk about Module 10, which is end of life and our oncological emergencies. So you do have to be familiar with what signs and symptoms we are going to see when a client is either approaching death or has actually passed away, because education and monitoring is really important, um, so that we're aware, okay, now this client is towards the end stage of dying. So we want to make sure that the family is present if they want to be, or perhaps we kind of let them know, hey, this patient does appear to be approaching the late stages of death, so maybe they don't want to be present, right? So I want you to think about what are expected symptoms of dying and how might we be able to tell if the patient actually looks uncomfortable. Because our primary focus with anyone approaching death is that they're dying with dignity. If you know me, you know that hospice and symptom management are really near and dear to my heart, right? We want to make sure that the client, that the family is really supported during these times. So I want you to think about some symptoms here. We're going to go over these in class actually. But think about, how would their heart rate be? What are their respirations going to be? How is their skin going to look? Are we going to see pain? Are we going to see restlessness? Um, when you do think about this, I want you to think that yes, pain might be expected. We might see that, but we don't want to. So again, thinking back to what's anticipated and what's not. I might anticipate them to be uncomfortable, therefore I'm going to treat them for pain early. I don't want them to be uncomfortable. I don't want them to be restless. I would want to manage that. If they're moaning, would that mean that they're uncomfortable? So we have to pay attention to all those cues when we are assessing our clients. So depending on the stage of death, you can see that their symptoms are going to start to change. So any client in the late stage of death is going to have increased secretions, and they're going to have a worsening ability to swallow. So they're more likely to aspirate and choke. The respirations are going to become rapid and labored. That's also what is known as Chine-Stokes respirations. They're not really slow and deep. They're really rapid, fast. They may develop loss of interest in activities in the early stages of death, a change in appetite and thirst. Usually it's decreased, is expected also in the early stages of death. But dyspnea, increased secretions, congestion in the airways, you can hear those secretions. They're breathing faster. They might develop delirium, pain, Chine-Stokes breathing. All of that can happen in the late stages. If you're looking at their skin, it becomes cold and mottled. Remember that color changes. We don't want to see those changes, right, in a client that we don't expect to be dying. That's why I'm always saying you really have to always pay attention to the skin, circulation. If they do develop towards these 8 stages, the congestion, the wet sounds, we do tend to treat those symptoms to keep them comfortable, because imagine someone laying there unable to swallow, how uncomfortable that would be. So you can do things like the anticholinergics to get rid of some of the secretions to dry them. Maybe we would put a scopolamine patch on. Remember, you can put those behind the ear to help dry them a little bit. You may gently have to oral suction. I would never deep suction, but if there's notable secretions coming out of their mouth, you might need to do that. Always think about your non-pharmacological measures to promote comfort. We could have aromatherapy, massage, music. They can eat if they want to. If there's really not a restriction on that. So maybe a comfort diet. If they really want a milkshake, I would give my client a milkshake. Any type of spiritual assistant that they might want, we want to make sure we inquire about that during the dying process, so that they have those supports available to them if they want. Um, If we are thinking that if they are delirious at all, we might want to give them a medication, an antipsychotic, like haloperidol, or maybe a benzodiazepine to keep them comfortable, like lorazepam or midazolam. Um, we use that also. And we do make sure if that they don't have a full bladder that could keep them uncomfortable before we might try one of those medications. Because if they're not able to communicate with us, it's difficult to find out what is causing the delirium or the uncomfortable situation. So you do want to try and assess some things first. So you do have to be aware of the early, middle, and late stages of dying, again, so that you can kind of educate the family and the client if they're available to be educated. I would want to let them know this, what they can expect as this progresses. So any client that, again, is approaching death, we want to educate. Anybody that's really close to approaching death, you want to let the family know that their respirations may sound loud and wet during that stage. That is normal process when they're close to dying. So always think about the continuum, um, palliative care, hospice, curative care, right? So any client that qualifies for hospice must have a terminal diagnosis. So we have to evaluate the client. And I would say, okay, you do have 6 months or less to live. That's necessary, that 6 month time frame. I may have said the life prolonging and curative treatments, we're going to withdraw those. Um, we're, only going to use care as a PRN basis for things. They are not trying to do curative care anymore. So the highest priority for any patient, again, in hospice is death with dignity. Now, I have had patients that have qualified for hospice and then they live past 6 months. What happens at that point is you have to recertify them. So we would look at the whole case. I would say, okay, this patient has had multiple falls, they've had urinary tract infections. So therefore, I do recertify them. I do believe that they will most likely pass away in the next 6 months. So that certification is necessary. Let's say that they do a lot better. They feel really good. And they want to end hospice. They can also just end the hospice care. They don't have to stay on it. Another common question I get is, well, could they go back on it in the future? Yes, they just have to get reevaluated. So it's actually a hospice team that determines if they qualify for hospice or not, but anyone can place a referral to hospice. So that could be the nurse, it can be the family, the patient, anyone. So anyone can call any hospice service. A hospice nurse will go evaluate the client, and then there's a hospice team, whether that be the nurse practitioner or one of the physicians that determines if the patient qualifies. So I want you to think about, our end stage heart failure clients, our cancer clients. Those are some of the common diagnostics that or diagnoses that we qualify patients for hospice. Um, and palliative care is different. You don't have to have that 6 month time frame. Palliative care, they will work alongside the curative aspects and really just focus on symptom relief for the client. So it's another interdisciplinary team that can be a part of the client's care. So you could call palliative care. I could kind of look over the chart and say, hey, you could add this as well to kind of keep them comfortable. They would also assess their advanced directives. So we would maybe educate the client on what a DNR, DNI is, their code status, getting a will, a living will if they want one, to help kind of navigate with the family. So you could have both. So if you're a nurse, you're thinking about your clients, you're thinking about what's best for them in the grand scheme of things. You have to think about their diagnosis, their prognosis. You have to think about, do they have 6 months or less to live? How would they get hospice care? Some facilities do have inpatient hospice. But most of the time we want to be able to deliver hospice care at home. The biggest thing with hospice that's misconstrued is hospice is not 24-hour care. So you do have to have somebody that's available to help the patient at home. Now, those family and the patient can call hospice at any time, but it's not like we're not always going to be there. So you do have to have support where the hospice nurse can educate the family on how to do the medications, how to care for the client at home. You do have to think about who's going to contact hospice, who's going to place the referral. Are we going to have the primary care provider manage the patient, or are we going to have hospice provider because they have to sign the order for hospice? And then you have to determine once that order is signed, are we going to do this at the home? Are we going to admit them to an inpatient hospice unit? Are they going to go to a nursing home because you can have a hospice patient in a nursing facility? And in those cases, the hospice team visits the patient in the nursing home. So I did a lot of those home visits on hospice, and I do have a lot of patients that still live in assisted living, and I just have to visit them in their assisted living. Now, those staff members do follow the hospice orders. So they do have to actually call hospice if they want any new orders. But again, the hospice team are the people that are going to determine if the patient can stay on hospice, if they still qualify, and if they meet requirements for hospice to begin with. So again, palliative care, this is another specialty that you could consider working in. It's a great specialty. It's specialized care. We're really just going to focus on relief of pain and any type of symptoms. We're going to focus on stress management. It's limited. I mean, I could do palliative and hospice. Maybe they don't qualify for hospice just yet, so I'm watching them on palliative first. So we are typically, again, focusing on those terminal clients, but palliative care initially was developed because there was people were not getting their needs met as the aging population continued to increase. So we found over time that a lot of patients do benefit from palliative care because we're really just focusing on their symptoms and we're trying to maximize the quality of life for patients. So this is an interprofessional team. It can include nurses, nurse practitioners, physician assistants, social workers, chaplains, social services, everything. So it's really, really awesome. Now, I will say that depending on where you're working, like depending on the level, the state requirements, some patients on palliative care or hospice can still receive quite a bit of medical care. So in California, I was able to bring patients home on ventilators and they were still on hospice. But the goal was always to have the clients die at home. So we actually had respiratory therapy and I would send the patient home on the ventilator, and the nurses and RT and the family learned how to work the ventilator, and they were able to stay home on hospice. You could still treat urinary tract infections with antibiotics. Perhaps they would get an IV depending on the situation. Typically, though, we like to avoid those things. But it really does depend on the location. They could still get breathing treatments, right? Because we want to keep them comfortable. But the main thing is they can't get admitted into the hospital. You can't be under two services at one time. So I can't have a client on hospice and then they're also admitted to the hospital. They actually get discharged from hospice if they end up going to the hospital. So some family members do, they don't understand that. So the patient might seem uncomfortable. The family members might not realize that, hospice isn't 24/7 support, like they can't be there all the time. So the family doesn't like to see their family member like that. So they just call in 911 and send them to the hospital. If that were to happen, then hospice typically gets notified that they're in the hospital, and then we have to discharge them, and we would try and readmit them from the hospital back to home. So that happens quite frequent. So, what do you think about this? Now, this is the ethical dilemmas that we kind of get into when you are talking about hospice, because let's say a lot of these clients are getting routine opioids for comfort. So they are on liquid morphine a lot of the times because that dissolves. They don't have to necessarily swallow that. You might have heard the term like a blue mouth or Smurf mouth because that liquid morphine typically does make their mouth blue. It is a very high concentration of morphine, so you really only see this liquid morphine with hospice patients. This isn't something that we would give typically ever for just pain management. So you just put it in a syringe and then you would just cheek it into the client. So a lot of the times this might happen. So I might medicate the client and then shortly after they pass away. Um, so a lot of people often feel like, oh my gosh, did I cause this person to pass away? This is known as the ethical principle of double effect. So this states that a nurse conduct is moral, it's ethical, if the primary intent is to ease pain and respiratory distress. There's no evidence at all to support this cause and effect relationship in pain management at the end of life. So you don't have to feel guilty. You're not doing anything legally wrong, again, because you're not doing it with an intent to hurt someone. You're easing their symptoms and their pain. And this is another dilemma that the family members might feel as well. So you do want to educate the family members. A lot of the times they get nervous to medicate their family because they don't want this to happen, or they feel like they're making them a drug addict because they're treating them for pain. And this is not the case. So you do want to let them know, hey, if they appear uncomfortable at all, or if this is routinely scheduled, that they are giving them the pain medication. So the biggest thing here is that therapeutic communication and what is okay to say and what is not okay to say. Um, you can say things like, when the family is like, I don't know how to talk to my father, I don't know what to say to my mom right now. You can tell them that it's okay to say things like, thank you for the time that you spent with me, or I forgive you for this. Or they can say, please forgive me for whatever their examples are. It is okay for them to say goodbye. It is okay for them to say, I love you. Um, and when we are talking about things with the family, we want to ask them, how are you doing? Are you worried? Are you anxious about anything? What questions do you have? You can acknowledge if you feel that they do seem overwhelmed or that this is difficult for them. You can acknowledge that. I can see this is difficult for you. How did you hear the news? How are others coping? What are your favorite memories of the patient? I always love doing that with the family members. It helps them reconnect and, get some of those emotions out. You can ask them, what are you going to miss the most about this person? You can ask them, do you think that this patient is comfortable? Do you need anything right now? So those are some therapeutic things that you can say to family and the patients. What do you think about if there's a big dilemma, no one can come to an agreement, who would you contact? You have to think back to your legal document. So do they have a healthcare proxy? You would check if they have that legal will, but do they have a advance directive? You have to look at the legal aspects of everything. And if they're in the hospital, you might have to have ethics committee. You'd have to work with all of the interdisciplinary teams and make sure that all those documents are actually signed and accurate. Remember, if the patient is oriented, the patient is the person that makes those decisions. So this is why it's really important to make sure a patient does have an advance directive while they are alert, because we want to make sure that we're acknowledging what they want. That's the thing with being a healthcare proxy. It's not about what you want. You are supposed to be communicating with the patient and saying, okay, if I'm your healthcare proxy, what do you want? What do you want me to do when and if you're unable to communicate those needs? It's not about what they want. So again, if the patient is alert and oriented, they're the ones that can make those decisions. The durable power of attorney for healthcare, even if the patient was initially a DNR, if the patient becomes unresponsive, the durable power of attorney can change them to a full code. So this is why it's important for the patient to pick a durable power of attorney that they know will honor their wishes. As nurses, you can have this talk again with your patient if there is a family conflict. When family and the nursing or the healthcare staff do not agree on a specific action and the client is unresponsive, then those decisions may go to the ethics committee. So you want to make sure that you're documenting as much as possible in these cases. So what do you think are the differences between withdrawing care and assisted suicide? Do you think that assisted suicide is legal in Arizona? Well, it's not. There's physician-assisted suicide is legal in 11 jurisdictions. California is one of them, Hawaii, Montana, New Jersey, Vermont, Washington, and this is legal under the court. Um, Oregon was actually the first state to sign this back in 1994, and it's kind of gone through the ringer here throughout the years, but not everybody agrees with this. But we can withdraw care anywhere, right? So what I mean by that is I'm a patient. I was diagnosed with a terminal diagnosis of maybe, let's say, breast cancer, and I tried all of these chemotherapy. I tried radiation. I had surgery, but it metastasized, and I don't want to do any more care. Well, I can withdraw care and maybe go on hospice, but it doesn't mean that you're giving me a medication at this time to make me pass away right now. I will just pass away on my own. Um, there's no time frame for that, right? So you're not actually giving them a medication that euthanizes them. Physician-assisted suicide, it's planned. You actually would go in, they would give you a medication, and you would actually pass away. So that is quite different. And that is ethically, we could talk about this forever. But legally, I can stop, I can make my own decisions and say, I don't want any more medical care, and you cannot force that medical care on that person. So let's talk a little bit about postmortem care. So now you're the nurse and your patient has passed away. Now, I will say the first time that you do this, you will probably be nervous. And maybe a little bit uncomfortable. I know that the first time that I had to do postmortem care, I was nervous and I was a little uncomfortable. The patient was alone. They hadn't had any family visiting them. And I needed other nurses in the room with me so that I could do that. So the big thing with this is that you still want to treat the body with the utmost respect, and you want to follow the policy at your institution. So your institution will have a policy that outlines everything that you as the nurse really need to do. But the big thing that you have to find out is there an autopsy or not? So if the client dies unexpectedly, um, and if the family requests one, if the doctor requests one, if it's a child that comes into the ER and they're automatically, pronounced dead on the scene, things like that, sometimes those would warrant a medical autopsy. So you have to check if one's ordered before you start your postmortem care. Um, Even if an autopsy is ordered, you can still allow the family to spend time with the deceased client. I have had students ask me, well, how long can you really stay with the client after they've passed? It's variable. I've had family members in the room for hours and hours. Sometimes you do kind of have to go in and say, we are going to get ready to get the clients cleaned and ready to go down to the morgue. This is difficult. You have to kind of read the room here and see what the best way to kind of intervene with this is. But if they do have an autopsy, you cannot remove anything. So if they have a Foley catheter, you have to keep that in. If there's not an autopsy, you remove everything. So you would take out, if they're intubated, the ET tube, you take out all the IVs, you take out the catheters, anything, those things would be removed. Um, no matter what, if there's an autopsy or if there's not one, you should allow the family to pray with the body before you take them down to the morgue if they want. You need to answer any questions that the family has, and you need to apply any of the ID tags that are with the kit. There's a postmortem kit. You typically have to put a tag on the outside of the bag. It's normally locked once you zip the client in the bag, and you also put a tag on the client's toe. So you do have to make sure that all of that is done when you're doing your postmortem care. You do give them a full bath, you would change them. And typically what I say is if the patient passes away, make sure that you want to raise the head of the bed up. You don't want to have them lay flat, and you want to get their extremities down before rigor mortis sets in. Make sure they're comfortable. Take the jewelry off so that the family can take all their personal belongings with them. Sit them up, never lay them flat because we don't want to make any distortions of their face. So clean them. A lot of the times they will maybe have a bowel movement or something when they pass away. So you want to make sure that their dignity is intact before the family members come in. Family members can help you with the bath and the postmortem care if they want. That is a question that you always want to ask them. Now, again, you guys had organ donation come in the network and talk with you about everything. So remember, this discussion only occurs with training. You are not the one that's doing these discussions. So you have to follow the policy, and typically as soon as the client is pronounced dead, or if they're on hospice and we think that the patient's going to pass soon, there's a number that you have to call. You give them all the history on the client. They ask you very specific questions. You go over those with them, and they will determine if the client qualifies or not. If they feel that way, they'll have the organization come and they do all of this. So you just have to find out if they do qualify, if there anything that you need to do here. So this again just goes over everything. Um, I like to make sure that their hair is pulled back, that they look really nice. We shut the door. A lot of the facilities will have a little like cart that you can bring up, maybe with some refreshments for the family. So you want to make sure that the bed is changed, everything is new and clean before you move the client. You can keep the dentures in, close their eyes. Ask the family again what they want. Do they want where the personal belongings going to? The main difference between the adult client and an infant is that with the infants, you do swaddle the infant and you transport that client down to the morgue yourself. Typically, security might have to go with you down to the morgue because it's a locked unit. So a lot of the times you do have to call them when you're ready to bring your client down to the morgue. And it's actually a special stretcher and it's covered. Make sure that it is covered before you start walking somebody in the hallway in a body bag. That needs to be covered. You don't want anybody else to be seeing that while you're transporting somebody. So with the infants too, with the children, a lot of the times they will do special things like the handprints or maybe cut some of the hair, things like that, photos maybe. So you have to make sure that the family is involved. Involve them in planning, allow them to spend time. Again, allow them to do the postmortem care. Nurses can also help each other, again, if you're uncomfortable. We want to spend time with the family. We want to have a moment of silence, maybe. We want to make sure we're getting those debriefings if this is close to home, especially if you work in an oncology unit, you get close with a lot of these clients. I have cried with family members. I've gotten close with clients. And so it is okay to have those emotional moments with the family members. If we don't address these moral dilemmas, we can start to feel burned out, we can be disengaged, and this all results in poor patient care. So you do want to address these. Any type of emotional response is normal. So it's normal to have those feelings of frustration or anger. But moral distress is when we don't address these problems, and that is what can lead to nurse burnout. So again, only in cases when death occurs at home and is expected should emergency services not be called for the death of a person. So again, if I'm on hospice and I've signed that, I'm a DNR, DNI, we expected them to be dying, they don't call 911 when the patient dies, they call hospice, and then hospice goes and does the postmortem care in the home. So this is a case study that you guys can read through. We are going to do this in class, so I'm not going to discuss this now, but I do want you to walk through this on your own and try and answer the questions. So I'm going to go through this. I do want you to think about this. What if the patient, again, is using accessory muscles to breathe? What if the patient appears to be having a hard time breathing? What if they're delirious or agitated? I want you to write down what you think that you would be doing, and we're going to talk about this in class. Here's another question for you. You're caring for a patient with comfort care orders. They're using accessory muscles for breathing. You notice a gurgle. What are you going to do? I want you to think about this, write down your answers, and then we're going to go over this in class as well. I want you to provide an example of a patient that is accepting the dying process and what would you anticipate them to say. And then I also want you to consider an example of a patient that is not accepting their impending death and what might they say or what behaviors might those clients demonstrate. I want you to write that down and we're going to talk about this in class. So kind of to wrap up our end of life hospice care is kind of brief. Okay. I want you to think about, just your own emotional responses to these types of things. Again, how might we be able to support each other if we are going through this? And again, I just really advocate for those planned, scheduled unit debriefings to help with this. We can send family members cards. We can acknowledge those losses. We can always facilitate moments of silence to remember these clients. We can support each other by doing postmortem care together, and we can always encourage the staff to spend time with family. And we never rush family members in their grieving process. Remember, this is a really an interdisciplinary type of care. So ask the client their cultural preferences, never assume anything. So we wouldn't just call a chaplain without inquiring if that's who they wanted. Maybe they want a rabbi. So you need to see what resources you actually would be able to provide the family. We never make any promises that we can't keep. So please write down any questions that you may have about this content and we will address it in class. We end this with the oncological emergencies, which is actually pretty straightforward. So any type of client with an oncological emergency could have any of these types of problems. So a lot of these you already know. So bowel obstruction, I want you to think this is an emergency. This is also why we're always inquiring about someone's last bowel movement. We're going to see these more in clients that have colon cancer or pancreatic cancer, or maybe they have an abdominal mass of some sort, and it's just causing that obstruction. So it could be partial or complete, and it could involve any type of bowel. It could be the small bowel or the large bowel, but these patients are going to be very uncomfortable. They're going to be vomiting. They might have that abdominal distension. Their stools might be, not normal. They may feel like they still have to go or they're not fully getting all of the stool out. So we probably need to send them to the OR. There's really nothing else we would be able to do if this was a full bowel obstruction. So these typically go to the OR. We would still want them to be maintained NPO until the obstruction is fixed. So they might need parenteral nutrition until then, and we may have to give them some stimulants to help with digestion. So again, what you need to be doing to identify these are your GI assessments. We want to assess, are they nauseous? Are they vomiting? When was their last bowel movement? And was it normal for them? Do they have bowel sounds? Do they have abdominal pain? So those are some of the assessments that you'd be looking for. You could consider the type of cancer they have because they would be more likely to have this. You would want to send them for an x-ray to see if there's a lot of stool in their bowels. Um, are they on certain constipating medications? So those are some things we would inquire to determine if they had a bowel obstruction. The next one is hypercalcemia, which is a problem, right? So this is most commonly found in cancers that metastasize to the bone. So this could be breast cancer, lung cancer, renal cancer. Um, and again, it's because those bones are being demineralized. So we're releasing all of that calcium into their circulation. So this is not good. So you have to think about your symptoms of hypercalcemia. So those include muscle weakness, polyuria, they're constipated, they're having muscle weakness. The symptoms are really going to vary depending on the level of calcium. So how do we want to treat hypercalcemia? Well, we want to hydrate them. We give them normal saline, those isotonic fluids, because we're trying to excrete that excess calcium. You might also do the biphosphonates because those can help treat and prevent hypercalcemia in patients with bone metastasis. So you would expect that. Um, so monitor their labs and identify symptoms of hypercalcemia. So I would think back to, do they have metastasis? Okay, I know this client does have lung metastasis, and now all of a sudden they're having muscle weakness. So I would anticipate giving them fluids and a biphosphonate to help correct that calcium, and I would be monitoring their calcium levels. Um, Again, they could be bradycardic, they could be delirious, they could be constipated. So you have to be able to identify those symptoms to know, okay, they are experiencing symptoms of high calcium. What about leukostasis? Well, this is when we see an AML, which is acute myelolytic leukemia. And this is when they have really high white blood cell counts. And this has to do with those immature white blood cells that are just being produced and produced and produced. And this is what AML essentially is. So it most commonly affects the kidneys, the lungs, the brain. And what we have to do to treat this is giving them fluids. We want to decrease that viscosity of the blood. They may have to get chemotherapy, and we're going to support their symptoms, but we have to determine the white blood cell count first to determine if they do have this problem, and then we would treat it. So again, if I'm getting that, if my blood is really viscous, then I'm having sluggish circulation. So that's what can result in that kidney impairment. So it's just thick. So I really need to thin that blood out to help prevent that worsening kidney impairment. So we're assessing for occluded microcirculation. So if they started to complain of blurry vision, they're having TIAs, those mini strokes, they're short of breath, and always assess for signs of bleeding. Are they bruising randomly? Are they actually bleeding? Those could be signs that they're experiencing leukostasis. So I think of the word stasis, I think thick and it's not really moving well. And then leuko, I'm thinking my white blood cell count. And that is what helps me remember this. We have learned about pericardial effusions and tamponade. So again, if they have any sort of cancer found in the chest, like a lung cancer or a lymphoma, then they could develop a pericardial infusion. So again, they're getting fluid there where we don't want it. There's fluid in the space, they're getting pressure there, and it's impeding the ability of the blood to flow throughout the heart. So we're not getting good cardiac output. So what happens is they're dyspneic. That's the most common, although non-specific symptom that they're going to present with, and they're not getting good perfusion. So what do we need to do? Remove the fluid. You guys know this. So we could do a pericardiocentesis to remove that excess fluid. So what you're going to be assessing for is, again, signs of heart failure. Do they have muffled heart sounds? Are they fatigued? Are they having edema? Are they short of breath? The provider would probably do an image, an x-ray, right? A chest x-ray. They would see that excess fluid. Maybe they do an ultrasound, and then they would prepare them for a pericardiocentesis, and they would treat the symptoms as needed. So again, pleural effusions. If we're talking pericardial versus pleural, what's the difference here? Well, we're talking about the heart and we're talking about the lungs, right? But it's the same concept. So whether or not it's a pleural effusion, right? I'm thinking lungs. So I'm still thinking any type of tumor in the chest or breast. And this again could be in anyone with leukemia, lymphomas, and they're getting fluid in the lungs. So they're not able to breathe well. So it's compressing, right? All that alveoli, they're not getting good gas exchange. So again, they're dyspneic. They might be using their accessory muscles to breathe. They have diminished breath sounds. They're hypoxic. So if I'm hypoxic, then I can develop that confusion, anxiety, agitation. So again, what do I have to do for this? I have to treat it. So again, I could do a thoracentesis to remove that fluid. So again, it's a catheter. They would place it in the pleural space and they would remove the fluid. What about spinal cord compressions? This is going to be any sort of tumor that's on the spinal cord. So that could lead to a communication problem in the neural network. So this is where it depends on where the tumor is that will depend on what symptoms that they're having. So it really does depend on, again, the location, but what you might see is pain and sensory symptoms. So if all of a sudden they're developing numbness, tingling, they have motor weakness, and we know that they have a spinal cord tumor, you would be worried about a compression. So what they do, they treat this depending on where, but typically that's radiation because that shrinks it. So radiation alone might help with those symptoms if they can make the tumor smaller so it's not compressing as much. But they may have to have a laminectomy, which is surgery. They actually remove that lamina to open up the space so it's not as compressed. So that alone could also restore that function, that it can block that disconnect that's happening there. So essentially, they might need something like surgery to help with that. Um, so again, you're going to look for things like maybe they're having worsening pain, they're having tingling somewhere, maybe also they're unsteady when they're walking. That would be what you'd be assessing for. They're constipated. That's another thing. So maybe they haven't had a bowel movement in quite a while. You'd be concerned about spinal cord compression. Superior vena cava syndrome. This is something that we would most likely see in any sort of a chest tumor or lung cancer. And essentially anything that's compressing that superior vena cava. So we're not getting blood return. So we're having reduced return of blood flow to the heart and it's congested. So again, if I'm having all of that buildup in the heart, it's not being transported out, they're going to be dyspneic. That's the most clinical symptom for this, and edema. So these patients might have headaches. They might have that JVD very prominent because that blood, that congestion that's going on. They could all of a sudden, you could see like brachial veins. that could be superior vena cava syndrome. Um, but again, you're most likely to see something like dyspnea, and you're most likely to see a client with lung cancer develop this type of problem. So they would need to be treated for the cancer. So they're going to get chemotherapy or radiation, depending on where. We might give them steroids to reduce that inflammation. They might, if they're developing like thrombuses, we might have to give them thrombolytics. If there's any sort of concern that maybe the vessels are rupturing, they would need a stent placed. So look for those late signs of poor perfusion. You all should know your late signs of cardiac output, like confusion, their extremities are cold, they're tachycardic, and they're hypotensive. You're looking for that JVD, the edema, they're dyspneic. Those would be signs of superior vena cava syndrome in a client with cancer. Tracheobrachial obstruction is another problem that we might see in any sort of lung cancer. And it's tumor related. So there's a tumor there and it's obstructing the major air exchanging airways. So what do you think is going to happen here if I have a tracheal obstruction? I'm going to be wheezing. I'm not going to be able to breathe. So wheezing's going to be present if the bronchi are involved for sure. And if this is really obstructed, you may not also take breath sounds at all. Their lung expansion is going to be reduced, so they're not able to take a big breath in and out, and they're usually hypoxic. So this would be immediate relief of that respiratory distress, because if I hear stridor, I know there's an obstruction. So initially, I would do the bronchodilators. You'd give steroids to reduce that inflammation, and they're probably going to need a stent placed in the airway to actually open that up because they're obstructed. So this would be another emergency that you probably won't see this very commonly seen for sure, but you'd be assessing for respiratory distress, wheezing, and we would have to treat this right away with supportive measures. Tumor lysis syndrome is the last oncological emergency that you might see. And this is when it's really rapidly progressing. And essentially what happens is all these cells are dying. And they're just lysing. They're like releasing all those electrolytes. So it causes really severe electrolyte imbalances and kidney problems. So initially, what happens is most patients are really symptomatic, and they're hypocalcemic and they're hyperkalemic, because you have to think about where the cells or where the electrolytes live. They could be acidotic. So in those cases, you can see heart blocks, you can see tachypnea. Their phosphate levels are really high, and that can just make everything a lot worse. So when their cells are lysing, when they're releasing, we want to give them a lot of fluid. So we actually do large volume IV for this, and we give diuretics because we want to excrete those excess electrolytes, and their uric acid levels are just really high as well. So if we are seeing that lab results, then we give them resburicase. If it's already elevated. If it's not yet elevated, then we do allopurinol to prevent those levels from getting higher. Any electrolyte abnormality, you have to treat that supportively. So if they do develop kidney failure, they actually would need continuous renal replacement therapy. Remember, that's your emergent dialysis for an emergent problem. So if I were to see TLS, then I know that their calcium level is probably going to be low, because my normal range is 8.5 to 10. So they're going to be low. And if I have hypocalcemia, you have to think about those symptoms. They might have like first degree heart blocks. And this is where you develop those positive signs like the Chevesque sign. So that is something that you might see in tumor lysis syndrome. And again, you want to give them a lot of fluids, get rid of all the excess electrolytes that you can, and monitor their electrolytes for improvement. We want to see if these things get better. So again, the paresthesias is common with hypocalcemia. assess their kidney levels. So you would be doing the EKGs to see about that first degree heart block. You'd be checking the T waves for hyperkalemia, right? We'd be looking at that. Assess for hypotension. And you have to remember your neutropenic precautions because we're talking about clients with cancer. So they are immunocompromised. So you have to remember your hand washing is the best thing that you can do for any of these clients, right? And we have to make sure that our assistive personnel understand that the client is on neutropenic precautions so that they're not sharing equipment. So if I assign my UAP to go in and do vitals or do care for the client, remember that that's their single-use devices. They don't share things. In these cases, we don't do rectal temperatures on clients with neutropenic precautions, right? So you want to make sure that we're checking that they're checking their temperature daily. And in this case, if their temp is over 100.4, so that's 38 degrees Celsius, they have to report that. In patients that are not neutropenic, we might not care until they're 38.5 degrees. So this is a little bit less of a threshold. And when they're constipated, they can't do enemas, nothing rectally at all. And they can't have any pets, fresh flowers, no plants. So you have to make sure that the visitors aren't bringing any of that in the room. They need to have a private room. Avoid standing water and appliances because it breeds mold. So we don't want any of that. They're not allowed in crowds. They would need a mask when they leave the room. A lot of the times with the neutropenic precautions too, I might wear a mask when I enter the room. So remember your neutropenic precautions, the basics of these. For this content, going back on your oncological emergencies, this chart is really what you should be studying for this. Just be able to identify what the problem is. What are we going to see with this problem if the client comes in with one of these emergencies? And write down any questions that you have, and we will go over this further in class.